presentation, okay? There's some issues with the medication slide not downloading. Is that for everyone or just one person or two persons?
You can go to alternate formats and download it.
Okay, I'll take a look at it over the break. The medication slide deck is literally just kind of like a wave top view of everything you guys have already talked about in pharmacology. So that lecture should go relatively quick. So it shouldn't be too long on the lectures today. So first one we're going to talk about is grief and complicated bereavement. So this kind of goes into what is a normal response to a difficult situation where we don't want to pathologize what is a normal human emotion. But also kind of goes into prolonged grief disorder, which was added to DSM-5-TR. It actually is supposed to be in the trauma and other stressor-related chapter with PTSD, adjustment disorder, but it was pulled out separately because it's a good kind of intro topic to actual DSM-5 diagnoses and kind of a good kind of segue into making sure, like talking about how we don't want to pathologize what is a normal response for people. Okay? So this is kind of like your definition from the syllabus that we're going to be going through. Prolonged grief disorder, that was just added. So this is a cutout, a snapshot, so I was doing my best to try and edit the image and it would not let me. So my answer was, I'll just put a white box over it and dump the new text on top. That's how you get that weird font. Okay. So when you're talking about grief or a difficult situation with patients, which you guys are going to have to do, the worst thing you can do is just go up to somebody and be like, hey, like, your husband's dead. That sucks. Like, what are you going to do about it, right? So, and sometimes we have a hard time talking about difficult situations with our patients. So if you ever need like an outline to kind of write a script, which if your first time ever doing it, definitely recommend kind of running through a script real quick before you go into the room will be really helpful. This is what you can use, right? Again, orange circle, so I'm not going to test you guys on this, but again, something that can make you guys better clinicians as you advance on through medicine, right? Eventually, because eventually, you guys are going to be touching real patients and everything that goes along with that. Biggest thing I'll say when you're talking about a difficult situation is you don't want to be ambiguous and you don't want to make things kind of cloudy. You want to be clear and concise with what happened, and you want to show that empathy with that patient. You don't want to ever leave doubt in that person's mind that there's something that could have been done, that you could have done something differently, because that introduces doubt and makes that healing process harder, right? So clear and concise, be empathetic, understand where that person's coming from. You may not understand what happened, you may not understand that grief, but you can at least empathize with somebody who's struggling, somebody who's in pain, right? So this is the original model of talking about how somebody comes to terms with a traumatic situation, right, with life and death. A lot of you guys, if you had any sort of previous psych classes, you probably come into contact with this. There's also a really funny robot chicken sketch with a giraffe that falls into the quicksand that goes along with this. As far as like clinical applicability, this isn't super useful because patients are going to move in and out of these cycles throughout that entire bereavement process. It's not a clear cut, they go from step 1 to step 2 to step 3 to step 4. They can fluctuate throughout this entire scale multiple times while they're healing, right? But it's kind of nice because it allows you to kind of conceptualize when there's a difficult situation, the steps somebody goes through in a normal healing process. And I'll kind of give you guys a great example from my life about how this can be applied, right? So in PA school, I came through in 2016. I failed like 2 or 3 tests while I was in PA school, but there's only one test that I actually legitimately failed, right? One of the tests I failed was anatomy and physiology, which there's like 7 tests in that block, and it was my act of defiance where I was like, you know what, as long as I get above a 30, I can pass. I'm not going to study. I'm going to go enjoy my life. And I did, and I got like a 60, so I passed, right? The other one was something in emergency medicine, and I got like a 74, and then we got points back because it was kind of like shenanigans, and I got like a 78 at the end. So I was like, cool, good, don't care. The one test I legitimately failed, I studied my butt off for it, was pharmacology. Test block number 1. I failed it. I got a 74. I'm still upset by it, right? So as soon as I got my score back, I went through denial, right? I studied my butt off. There is no way that I could have failed this test. Not me, right? I spent hours and hours. I didn't see my family for more than like 2 hours in the week leading up to this stupid test. There's no way I could have failed, right? Denial, step one. Anger. Stupid instructor. Her and her stupid questions. That is the only reason I failed. These stupid questions are not clinically applicable. No real patient is ever going to need to know the stupid mechanism of action. This is dumb, right? Anger, step two. Step three, hey, I've been in PA school long enough now, we always get points back on every test, right? I'm going to get points back and then I'll pass, it'll be 76. I won't have to worry, it'll be fine. We did not get points back on that stupid test. I got stuck in a 74. So bargaining, right? Like, hey, it's okay, I can do something to get out of this situation, right? Then we kind of go into that depression stage. Crap, I'm never going to become a PA. Like, pharmacy is going to kill me, and then I'll essentially wasted the last 2 years of my life because as soon as I found out I was going to PA school, they didn't send me to boards anymore. They didn't send me to schools because they're like, hey, you're going to be an officer. This stuff doesn't matter. We want to send another NCO who's going to go on and go to Audie Murphy or something like that, right? So essentially, that depression stage of I'm never going to be a PA. This is horrible. Nothing's ever going to happen. Everything's wrong in my life. Depression. Then finally, like, okay, I failed the test. I can move on. You kind of move into that acceptance phase. You're accepting the situation that you're in, the outcome from that, and you kind of rationalize it. You're good to go, and you move on from there. So that's kind of my personal example for how you move through all of these different steps, right? And obviously, that's kind of joking, fun, but it highlights how a patient can kind of approach this. And if you've ever dealt with any sort of like grief or trauma in your life, if you actually kind of look back on it, you'll realize you kind of follow these steps. When your patients, when they're grieving, when they lash out at you, just realize like it's not personal, right? They're kind of coming to terms with what's happened to them. That anger is to be expected, right? When you tell somebody like, hey, your loved one's passed, or hey, your career in the military is over because of this condition, and now you see them a month later and they're all sad and depressed, don't diagnose them with major depressive disorder. Be like, hey, that's a normal response. They are appropriately moving through their stages of grief. I don't need to pathologize them, right? When patients are bargaining with you, like, no, I can still serve in the military, or like, no, he'll come back, like, you guys messed up, something happened, they're trying to bargain, is there something else we could do for him? That's an appropriate thing. They're not trying to go against you. They understand what you did, but they're trying to bargain. Again, it's a normal emotion as you're moving through this process. So grief, you kind of break it into these different categories, right? So now we're kind of getting into just the normal person. They're going to flow through all those different steps all at once. So you have your grieving, your mourning, your grief, complicated grief. This is where it starts to turn into an actual disorder here at the bottom. So now it's affecting their life. It's gone on longer than it normally should, right? They're not responding in those appropriate clinical norms. Grief can be very, very intense, right? So if somebody just shuts down on you after you've given them bad news, that's acceptable. Give them their time and their space. Get the chaplain. Chaplains are amazing. They are an awesome resource. There's a reason that they're in all the hospitals. That's what they're trained to do. If your unit has a chaplain, they're a great resource. Let them know. Because also the chaplain has that kind of HIPAA. They don't need to share information. They're a great resource, and they can help in this acute phase of the grief. Because obviously, you need to tell the patient what happened and then move on. You've got more patients to see, right? You don't have the time to sit with that patient as they're going through this process. Those steps that we've outlined, that adaptive style, denial, again, that person's going to flow through all those steps, maybe all at once, maybe quickly, maybe they'll back and forth between the two. It's a steady flow. It's not clear cut. Like, that's where we kind of remove that model. We don't necessarily keep test you guys on that. Okay. Anguish, despair over time. So pangs of grief, again, it starts off really, really intense. If you've ever had, another great example, if you've ever had like a really bad breakup, right, with the person you thought was the one, maybe your high school sweetheart, and then you guys broke up because obviously one of you had to go to college or join the military or something happened, and you felt your world was ending, right? And you just sat in your room and you listened to, I don't know, Britney Spears or NSYNC or something like that in your room over and over again on play, right? That's your normal grief response. That's okay. You're in anguish. It hurts. But then over time, it gets better, right? You realize, like, hey, there's other people out there we weren't right in our stage of life, and it kind of gets less and less and less, and then you get better over time. That's how grief should be. It's really intense anguish at the beginning, and over time, as somebody heals, it gets less and less. It doesn't go away completely, but now all of a sudden, it's not as common. They're able to get out. They're able to leave their room. They turn off instinct. They don't listen to it anymore, right? My dating, look, I don't feel like I'm not that old. I am not dating myself with that reference, all right? Screw you guys. So integration phase, so again, they go from that acute phase to that integration. Integration sounds exactly like what it is. Like us in the psychiatric world, we're not super creative. They're engaging again with their friends, their family, they're leaving their house, they're going back to their job, they're having that integrating back into society, right? That's what you want. And hopefully, they learn something, right? You always want to have that good learning lesson at the end. Like, down there. They emerge with a new understanding. Okay. And then finally, you kind of start to go to that resolution. A good idea of whether or not this is going to turn into an actual condition or not is, again, the more isolated somebody is, the more likely they are to go into a disorder. The more of a network that they have, the more likely that they're going to appropriately heal. We never want our patients to start to isolate themselves and withdraw. That usually is going to lead to a bad outcome over time. Okay. So, last thing I'll say before we kind of jump into the actual prolonged grief disorder. If you guys are thinking about grief and stuff like that, how somebody progresses, this is why, as different cultures, they've all developed kind of like these elaborate funeral kind of rituals, is it helps with that healing process. So that's the reason that the funeral industry kind of takes off. That's why we have open caskets so everyone can say goodbye to the person. That's why some people have a wake, a huge party to celebrate that person. These rituals around death, we as human beings have developed them over time as a way to help us heal and kind of progress and move through in those phases, right? The more traumatic that the death is, the more traumatic that the grief is, the more isolated the person is, or if they don't have time to appropriately go through these death rituals, the more likely it is that somebody's going to turn into prolonged grief disorder or major depressive or some other condition, right? So don't ever belittle somebody's cultural death practices, right? You don't understand where that person's coming from. You don't understand what's normal to them. All right, so now we're going to get into actual prolonged grief disorder. This is your guys' first actual DSM-5 diagnosis. And what you'll realize with all of these DSM-5 diagnoses is that there's certain criteria that has to be met in order to make that diagnosis. Because again, the biggest concern is we don't want to pathologize and give somebody a label to what is a normal human response. We're all supposed to be sad. We're all supposed to be anxious. We're all supposed to be angry. Those are normal emotions. It's when they start to meet criteria that it becomes something bad, right? So a big thing when you're talking about prolonged grief disorder, this quick snapshot view, time frame is going to matter. So anything that's equal to or over 12 months, now all of a sudden they satisfy box number 1 for prolonged grief disorder, right? In children, so remember in this course, we're going to use 18 as our cutoff, which is kind of a lie, but we're trying to make it as clear cut as we can. We're going to say 6 months in kids. So make sure you know that difference. It's going to matter if we're talking about an adult versus a kid. Time matters, right? Next is that persistent yearning or longing. So they have to keep wanting to have that connection with the deceased individual. If they're not really having that and they don't satisfy the next criteria, they don't have this diagnosis, it could be something else. So that theme for this disorder has to revolve around that deceased person, right? So kind of keep that in mind. Next, just recognize that prolonged grief disorder, it commonly presents with other things. I'm not going to give you guys a question where they have a ton of comorbidities. I'm asking you which one is which. That's kind of above the primary care level when you start tacking on lots of diagnoses. But just realize a lot of these conditions can present as prolonged grief disorder. They kind of mimic each other. What you need to identify is what was the primary cause that triggered all of this. Once you've identified that, now you can start linking it in with an actual diagnosis and kind of start coming up with your plan for treatment, right? Next, increased risk of suicide and suicidal ideation. That's pretty common. That suicidal ideation is going to be more along the lines of I can't live without this person. how do I go forth moving? I want to join them, but they don't ever turn it into a plan. They don't ever state preparatory steps, and that suicidal ideation is going to lessen over time as they move through those stages of grief. So it's definitely something to talk with your patient about. Make sure that they're safe, because if somebody is not safe, what do we do with them? Going back to our suicide lecture. Yes, you do, right? So again, if somebody is not safe, we don't let them leave, right? Either you need to get them to the ER, you need to get them with Psych. Never let your suicidal patient just take off if they're not able to keep themselves safe. Perfect. Prevalencey rate, do you guys have any idea why it would be higher in youth than in adults? Let's go through mechanisms, definitely, right? So again, that child brain is not fully developed. They express things in a different way. What else? What about manner of death? Are kids supposed to die?
No.
Not really, right? So a lot of times with youth, it tends to be more of a traumatic death. So you're thinking like car accidents, suicides, overdose. Whereas with adults, it tends to be more of that chronic disease. They tend to die like you're supposed to, right? So that manner of death also plays a part when you're talking about prolonged grief disorder. Yeah. Oh, whoa. What are these questions?
Are we talking about the person that died or the person who has the
See, these are the survivors. Yeah.
So wouldn't the adults be more suicide?
No, so, okay, sorry. I did a bad job explaining. Hold on, let me rethink real quick. All right, so prevalence rate. So this is the people who are going to go on to develop prolonged grief disorder. So these are the survivors, right? So then, of your adults who experience grief, 10% of the adults are going to go on to develop prolonged grief disorder, right? Then in your children who experience grief, 18% of them are going to go on to develop prolonged grief disorder because, one, the brain, they're not fully developed, but also the manner of the death matters. If it's a more traumatic death, so it's not just like cancer, old age, dementia, but it's like a car accident, a suicide, a murder, they're going to be more, if they're friends with that or it's a family member, they're going to be more likely to develop prolonged grief disorder. It's a risk factor. Does that answer it? Okay, sorry about that. Good point. I hope I correct. 5 hands shot up. I hope I clarified it. Yeah.
The criteria being shorter than
So not necessarily, no. It has to do more with how kids present and how they act out stuff. And we want to involve ourselves with the kid a lot quicker because they can have worse outcomes in the long run. That's why we shorten that time frame down for kids, because we want to intervene quicker when we can with kids because they can have detrimental effects for their lifelong development. Yep.
The development, when you say like traumatic stuff or stuff that you like isn't from a chronic illness, like, or do they actually physically watch them die? Does that play a role?
Yep, that's a risk factor, right? If you are actually the one who witnesses the traumatic event, it's a lot more, again, it's risk factors, you're just stacking that risk. And never guarantees. Don't ever think that because somebody has like all these risk factors, they're guaranteed to get it. It's just when you're playing the odds and you're gambling, it increases the likelihood, right? But again, I've had people who've had everything go wrong with their life, and they keep trucking along. Whereas the one person, they get a burr in their shoe, and it's the end of the world, right? Everybody responds differently. All right, good. So now we're going to break down the full criteria. So if you look in the DSM-5-TR, there's going to be these pink boxes, which we'll bring up in just a second, and it lists out all this criteria. This has to be met in order to make the diagnosis. So the DSM-5 is, just keep in mind, the DSM-5 is not a book on how to treat people. It is legitimately a diagnostic manual, and it's a billing and coding manual. It allows us in the psychiatric field to communicate across specialties and say like, hey, based on this criteria, this person has this disorder, and it standardizes it, right? And it gives that diagnostic code, so now I can bill for it, because I'll show you in a second. Right, so when I'm doing research, it also kind of standardizes our research, right? That's one of the downsides to the book, that's why people complain about psychiatry. They say it pathologizes normal responses because we have to use this criteria. It also matters in a legal sense. So if you're dealing with a legal case and you're trying to make an insanity defense, you're trying to make malingering or saying that this condition caused X, Y, and Z, forensic psychiatrists, they will make sure that you match each one of these criteria, right, to say that you have that diagnosis. So, again, you have to experience the death of someone close. So this can't just be something that you see on the news. You have to have that connection, right? You need to have at least one of the two. So 12 months, 6 months for kids, intensively yearning or longing, or preoccupation with the deceased person. So you have to have one or the other, or both. But you need that. Once that's done, you satisfy criteria B. Then you go into criteria C. C, you only need to have 3 of the 8, right? And again, 12 months for adults, 6 months for kids. And it can be any of these. And again, as you'll notice, this criteria tends to evolve around the person and then their emotional response to that, right? So they start to avoid it, they have this intense pain, they feel lonely, they start to isolate, they don't have a reason for living anymore. This is very similar to kind of like PTSD, adjustment disorder, that's why it's all sectioned together, but you only have to have 3 of these, right? When I'm writing a test question, I'm not gonna try and be like, aha, got you, they only had 2 of the 8. I'll make it pretty clear cut, right? They're gonna have more than the 3, they'll have 4 or 5 if this is a test question, right? But the way I could try and get you is that time frame is gonna matter, or if I paint you a scenario where the person is getting better, their symptoms are lessening over time, because again, I wanna make sure you guys understand the difference between a normal grief response or prolonged grief disorder, right? So think about that when you're looking for the studying material. Right? So this is the pink box that comes out of the DSM-5 TR. So again, there's your diagnostic criteria listed out, and over here, that's your billing code. So if you guys are making this diagnosis in your primary care clinic, this is the code that you would use. You plug that in, it'll pull up the ICD-10s, and you can bill for this.
What was the acronym?
So I have been trying to figure that out. It was from the previous lecture set. I left it in there for now because I'm trying to figure it out, but that's why I was going to go into here real quick. So this is where you're talking about right down here. So it has to have some sort of emotional or occupational impact on that patient's life, right? I think that might be OOPT, occupational or organizational. It has to have some sort of impact on that person's function, right? So that means that they're not going to work anymore. Maybe they've dropped out of school, right? So they're not going to school anymore. They're isolating, they never leave their house anymore. If they're honky-dory and they're hanging out with friends and family, they're leaving the house, they went back to work, back to school, now all of a sudden they're not meeting that last criteria, right? These last two, this is kind of like the catch-all type deal. So again, it's outside of what is the realms for that normal culture, spiritual religious response. So if you're normally supposed to mourn your dead for over a year and that's culturally acceptable, they don't meet criteria, right? If it's not, this is going to be the same down here for all of your behavioral health disorders if it's not better explained by something else, right? And that's where I tell you guys, make sure that you rule out organic etiology first, because that will clear you from this last one. And this stays the same for all of your behavioral health disorders. You'll see that as the very last criteria. So they can't be taking a crap ton of cannabis to the point where they never leave their house and it revolves around the marijuana. That wouldn't satisfy the criteria because the cannabis is causing them to isolate, make all their symptoms worse, make them withdraw from society, in which case then you use a different diagnosis. So that's your criteria. Any questions about the criteria? Make sense? I see head shaking sideways, so that means a no. So I'll just run through it real quick. Yes?
Sorry, so when you're looking at this intense yearning or longing for deceased person or preoccupation with thoughts, if you lose somebody close, I feel like that's just going to persist with everybody. Is that?
So it does, right? That's where time frame matters, right? So when that person initially dies, well, yeah, you're going to have thoughts about them. They were someone close to you, right? Because it has to satisfy that first criteria. Well, now what we're looking for over time, have you come to acceptance? Yes, they're still in your thoughts, but it's becoming less frequent. They've moved from that primary figure to more of a memory, right? And it's something that you honor over time. A great example is if your kid dies, right? Initially, like, it's going to be rough. Having a child die for a parent is a very rough experience. Over time, they're not going to want to change the kid's room. They'll leave it as is, right? Maybe they'll have photos of that kid, but then the normal grieving process, they'll have the funeral, they'll have the memorial, maybe they do a headstone, they're visiting the grave pretty regularly, but over time, they take the room, they'll change the room out, they'll take their stuff down, they pack it away, It's not every single day where they're crying with the picture of their kid who's deceased, right? They kind of put that away, they grieve. So the memory's still there, you're never gonna forget your kid, but it's not the predominant point of your life, right? If the deceased stays as the primary point of your life, that's where it becomes a disorder and everything starts to revolve around the deceased. That's a problem, right? Because now you're not going out, you're not engaging, you're not going back to work. Everything is about the death of the individual. Now it's become a disorder. Does that answer your question?
Yes.
Okay, cool. So remember, when you're talking about this criteria, first bucket I need to fill is bucket A, right? So the death at least 12 months ago, 6 months in a kid, they have to be close. You have to fill that bucket first, then you move to the second bucket. Since the death, do they continue to have intense yearning or preoccupation with? This is after 12 months in an adult, 6 months in a kid. If I filled that bucket, now I can move on to the bucket C, right? So since the death, so again, now you're past that 12 months, past that 6 months. Do I have any of these 8? So I need 3 of the 8. If I have that, I'm good to go. Now I can move on to bucket D. Is this causing a significant impairment in their life? That should be pretty straightforward because you're going to ask them what they've been doing and they're like, nothing. So you satisfy that. And lastly, E and F, this is where you have to kind of know your patient, know the culture that you're a part of, and you kind of do that good history to make sure it's not something else significant. That's where your review systems can come in. You know, I've done that, I'm good to go. I can make that diagnosis, okay? All right, so associated features. So what will happen over time with this person if they're starting to reach that criteria for prolonged grief disorder is you'll actually notice a change in their thinking, right? I'm not going to test you on the definitions for this, but just kind of the biggest thing with this when you're talking about cognitive distortions, because this will play a part in a lot of our disorders, recognize that there's a change in their thought pattern. So instead of being able to recognize the good in the world, recognize that the world is gray and there's all sorts of positives and negatives, they tend to sort themselves into one of these thought patterns, right? So catastrophizing, if something bad is going to happen, it will happen. Every single time. There is no good in this world. I always go to the extreme. That's catastrophizing. All or nothing, this is kind of like that very black or white. And a great example of this is either everyone is with me and they understand me, or everyone is against me, right? Which isn't reality. The world operates in shades of gray. But they tend to go into that all or nothing thinking. Overgeneralization, that's just kind of like where they aren't able to recognize the details and they kind of consider everything with a broad paintbrush, right? Mind reading, this is where if you've ever talked to somebody and you're like, man, this guy hates me. You have no idea what that person is thinking. You're thinking you can read their mind and you're assuming that this person hates you, when in fact they probably don't, right? So mind reading, personalization, that's exactly what it sounds like. You're just taking everything as a personal attack or personal affront to you, right? Emotional reasoning, this is kind of like where you're trying to say that, hey, my emotional response is appropriate given the situation. And then should statements, this is kind of where you get into that, well, if I had done this differently, or I should have done this and a better outcome would happen. So again, I'm not going to test you on those definitions, but just realize a person's mind is legitimately going to change once they start to hit that disorder category. And I have a handout I'm going to upload. I'm just trying to find it in one of my dang folders. All right, somatic complaints. So this is where, yes?
Sir, sorry, going back, you just said that's an overall change in thought process?
Mhm.
That's what it was, thought process?
Yeah. So essentially, instead of just the change their thought, and now they're approaching life from one of these viewpoints, right? So somatic complaints, this is where they can end up seeing you guys as the primary care first, is because they're going to come in, and a lot of times they can actually start mimicking the symptoms that the patient had. So if they died of like stomach cancer and they're the survivor, they can actually start coming to see you because they're having stomach pains now, and you're not able to identify a clear cause, right? Or maybe they just have back pain, but there's no real reason behind it. Those are somatic complaints. That's how they're coming in to see you all at the primary care level. And that could be the presenting complaint, right? So this is health concerns, other conditions. This is stuff that can go along with prolonged grief disorder. So a lot of times they can have that PTSD, anxiety, substance abuse. There's something else comorbid with it, which is why we want to address it. Or they can start to have those harmful health behaviors. So this is that simple, like they're no longer taking care of themselves, right? They're not showering regularly. They're not cleaning their house regularly. Maybe all of a sudden they're not paying bills, and there's that risk that electricity is going to be turned off, water is going to be turned off, right? Because they're just not getting out and doing anything. There's other effects that go along with this disorder. Hallucinations. This is something that's very common. And this is where it's important for you guys to tell your patient, like, hey, no, you're not psychotic. You don't have schizophrenia. The fact that you've been married for 50 years and your husband just passed and you're hearing his voice, that's a normal thing, a normal response to have, right? And it's going to lessen itself over time. It shouldn't start to become more predominant. But and a lot of times this will happen when somebody is going to bed, kind of into this hypnagogic state, where you're not fully awake, you're not fully asleep, your brain is starting to shut off, and they'll kind of miscue on stuff in the environment. So that's where you start to hear, you see a shadow on the side of your eye, and you think it's a person, and you wake back up. That's a normal response. We don't want to pathologize that. If you hear a voice kind of like out of earshot and you turn to look, that's what we're talking about with that speech hallucination. It's not actually communicating with you. It's not giving you ideas. It's not telling you a tone, right? So with this hypnagogic state, your sleep demon that you encounter every night when you're going to bed, it's not an actual sleep demon. That's a normal response. It's just your brain miscuing as it's shutting down, right? And then emotional dysregulation. Again, this is what we've talked about. It starts to become predominant. So again, if somebody is angry, they're bitter, they're resentless, they're restless, that can be a normal response that can happen with prolonged grief disorder. Recognize that they're not targeting you as the provider. They're having something that's going on. It's to be expected. They can have these conditions, right? Don't take it personal. Development. So over time, so a lot of times we'll start to show these symptoms within the first few months of death or the passing of the deceased. We don't make that diagnosis yet, but you can start to see these warning signs start to pop up if you're seeing this patient or it's a friend of the family or something like that. So it can start early on, but we don't want to intervene early. In those scenarios, that's where it can be helpful to be like, hey man, like, have you talked with anybody about this? Have you talked with your religious figure about this? Have you talked with friends or family? To try and intervene early. But it's not diagnosed yet, we're not going to start significant treatment on the psychiatric side, right? Highest risk of development, so this is where we're talking about who's at risk for developing prolonged grief disorder. So again, the closer you are to the relationship, the more traumatic the death is, and the more likely that person was supposed to keep living, that's going to increase your risk. So a child is always going to be a bad deal for the parents, right? It increases their risk, okay? Violent death, so this is where you're talking about a car accident, a murder, an overdose, a suicide, especially if you're the one who found the body or witnessed it. It's going to increase your risk for that, okay? Violence, again, we're talking about older age. So if you're, this is where you kind of start to get into our geriatric population, because eventually we all die, right? And if you're the primary caregiver for your significant other, because they're wheelchair bound, maybe they start to have crippling osteoarthritis or something like that, and now that primary caregiver passes away, it can be very detrimental to the other person. That's why when you've been married for a long time, or you've had a long relationship with someone, when one person passes, it's pretty common that the other one's going to go within a year or two, right? Just because it's such an effect on their health and their mental well-being when that relationship is severed, okay? That's what we're talking about with this one. And again, death of a family member is always going to be more significant than the death of a friend. You can still get this from friends, especially if it was a close relationship, but it's going to be more common and more severe with family members. And lastly, with children, this is why I was talking, we want to intervene early with kids. Kids are always going to present differently than adults. Who in here has young kids, right? So how does your kid act when they're like overly tired, like to the point where like you know they need to go to bed but they're fighting you? How do they tend to act?
Great.
What's that?
Like assholes.
Like assholes, right? So how would you describe an asshole?
My kid.
Right?
Just
So,
Irritable.
mean, short-tempered, right? Maybe they start to become a little bit destructive, right? Because kids, that's how they're processing information. They don't have the words yet. Their brain's not fully developed. When you're talking about a mental health disorder in a kid, that's a lot of the times how they're going to present, because that's how they're processing emotions. So a kid who's experiencing prolonged grief disorder, it's almost going to be the exact opposite. And this is going to be in your young kids. So this is, we're talking about like 4 to 12-ish. Once you hit that adolescent teen it starts to align a little bit more with the adult, but it's not perfect, right? And this is where I say like that 18-year cutoff is kind of a little bit of a lie, but to make life easy, that's what we're going with. So kids, a lot of times they express emotion through play acting. So if you're watching a kid and you're working with them, and you're worried about prolonged grief disorder, asking the parent what they've been doing. So a lot of times they'll play like on the ground, saying they want to be closer to their relative. They'll want to play with ladders and get higher because they think they connect with them. Because again, kids express their emotions through play. So ask them what their play is going to be. Developmental regression. So if your kid was potty trained and they were on top of it, and now all of a sudden they've gone back to diapers, that's regression. They're not reaching those milestones anymore. They've gone backwards. That can be a sign that something's going on. A great example for that is I have 4 kids. Every time we've PCS'd, my kids have always gone back a little bit in their development cycle, just because you're ripping them away from their friends and family, you're changing locations, changing house, packing everything up. It's kind of a rough example. So if you think about how your kids act when you PCS, it's going to be like that, but a little bit more severe, because obviously it's a more significant condition, right? This is where you start to get into your older kids, so defiant behavior. So now all of a sudden, they're not eating their foods anymore. They're not going to bed anymore, okay? They're starting to act out against you, trying to fight you. Again, your kid's not being an asshole. They're trying to process their grief, okay? Intense worry, safety as a caregiver. This is where that kid starts to get really clingy and they won't leave their side, or anytime the kid leaves the room, they break down crying and in tears, right? That's what we're talking about with that, because they're worried. They've already had one caregiver die. They're worried about the next one. And if this isn't addressed, it can start to affect them when they become adults, and now all of a sudden they're not leaving the house anymore. They don't want to move out, they don't want to go to college, they don't want to go to school, they don't want to leave their hometown, they don't want to progress into marriage because they've had this significant event as a kid, and they're worried about it repeating because it wasn't addressed properly, right? That's where you kind of get into this bottom one here, right? This is your older kids, this is going to be teenagers. That's where you start to see that risk-taking behaviors. That can take the place of like, okay, the male teenagers are already dumb, but now all of a sudden they're taking like super aggressive risks where they're driving crazy fast down the highway, they're not wearing a seatbelt, right? Maybe they're starting to drink and drive, they're staying out late, they're not going to school. That's what we talk about with adolescents. You start to see a lot of that risky behavior where they don't care anymore about life, right? That's what we're talking about with them. Good. So functional consequences, this is your adults. So what I was telling you is it taking an effect on their life. This is what I'm talking about with here. And this is really why we care, especially you all as the primary care, because you guys are going to be the ones who deal with all of this stuff, right? Somebody who has prolonged grief disorder or any mental health disorder, they're going to be more at risk for developing health conditions, right? These are your kids, so again, we want them to get better because we don't want this stuff to happen. And then in your elderly, that cognitive decline, so again, if you're old and your best friend dies, who you spent the last 60 years with, you take a hit. They tend to go downhill pretty quick if they don't have another relationship to plant that. And that's where you start to go like, hey, Granny's been hanging out pretty well. Yeah, her mind's starting to go, but she's still active, she's still out, she plays with friends, she goes to pickleball court, and then they have a death, and you're like, holy crap. Like, she doesn't remember who I am anymore, she's wheelchair bound, she never gets out of bed, because they had that relationship severed, and now they're having those effects from that, right? So, when you're talking about your differential diagnosis, look at that. There happens to be 1, 2, 3, 4, 5, 6 options, right? That's crazy. So, your differential matters. That's why you need to make sure you're making the correct diagnosis and not getting distracted by one of these, right? So when you're thinking about the disorders and how they present, because we haven't talked about these other ones just yet, always know the identifying cause, what caused these symptoms to start, know your time frame, how long it's been going on for, and know what symptoms they're presenting with. Like, okay, depression is more apathy, low energy, don't want to go out and do anything. Prolonged grief disorder is more revolved around the deceased person they have. That becomes a predominant point of their life. That's how you can kind of separate out the two, okay? So, treatment-wise, our goal is obviously we want to get the grief to resolve. This is where it's important not to pathologize, because if you tell somebody they have prolonged grief disorder, there's more than a likelihood that they're not going to get better. You need to reinforce to them, like, hey, this is a normal response. You're moving through the appropriate responses. I don't think we need therapy. I don't think we need a medication. Let's just kind of get you some psychoeducation. Let's get you linked into the community. This is where social work can be a huge help, right? first line treatment once they've actually made that diagnosis. So first line therapy is always gonna be cognitive behavioral therapy. That's the main psychotherapy modality that we tend to use a lot. You'll hear that quite a few times. It's a little bit of a lie, but as far as like primary care goes, CBT, if you don't know what else to answer, go with CBT. You'll be right like 8 times out of 10, right? That's our building block. We use that for everything else. Once we start to hit into medications, you guys want to take a guess on what awesome meds you should use? SSRIs. SSRIs are going to be like your go-to for the majority of these conditions, right? We're going to have our psych. We're going to go over the meds real quick in the next lecture, but just realize you guys have had your pharmacy class, so all of those meds are fair game, right? So I'm not going to test you on your knowledge of, well, what drug class did you use? I'm going to give you a list of meds. You need to be able to keep identifying the SSRI versus the SNRI versus the TCA, right? That's kind of the expectation. Because you guys are going to be prescribing these meds, and when you prescribe a med, you're not giving them an SSRI and telling the pharmacist to pick their favorite one. You need to be very specific in the med you want, the route you want, how much to take. Does that make sense for everyone? All right, cool. Any questions about kind of grief, prolonged grief disorder, kind of how the pink boxes work, or anything along those lines? All right, going once, going twice, going 3 times. All right, cool. So go ahead and do the 10-minute break, and we'll get set up for our next lecture.
He talking shit and they both not even in the playoffs. Like, period.
Yeah. Yes, that was the. Oh yeah, the
She got prorated typing
Never gone to preschool daycare.
I'm trying to update this up as the syllabus DSM-5. So I'm trying to update everything. Like there's some conditions we've added that are favorites.
Are they coming here for the next one?
And then we don't really know that's talking about as well.
I got inducted. So basically, it's like you go to a bunch of work,
So you go to the audience work, you get it done.
yeah. I failed the first time, so they do like ask you a written test and do like a 5 pass. So the first time I failed the written test, I won so like all these regs, you have to like study.
You know that we're special.
I never thought I was good at work. Like for my 5 to 6, I had to go 3 times.
Yeah. Is there right were you like volunteer? Did you want to?
I wanted to. I really enjoy what they do. They do like a lot of like
If you buy it online, it's fine.
yeah.
Yeah, that's okay. I think
I can keep it 2 years. On my first week too, I picked up E7 on my first week on the first one. I helped 2 people there. That was like the start of story. And I would love to do
How do you feel about I know we have meetings on next Friday.
It's like if you have to study this bio, this bio. Adriana Review was a legend. A war hero movie. I was verbatim. They can even have the standardized movements. Stop me. Ask guys question. So it's an individual. You don't get something right now. I would love to. I was the president. I was president of the chapter. It's a big league club. People who really
You get a fancy medal for reciting a creed, answering questions, and making
I have to jump through hoops to be
Yeah.
here.
I'm not single. I have a family.
You were a Jew. People
Hey,
were
my
Jews.
husband is
That's what
Meant
makes
to
you
say people know something.
I have social life. I post a couple pictures on my Instagram.
It's just frustrating because
Bring your own chairs, that's what I do. But I tell these guys, bring your own chairs. BYOC.
That's why you should.
no, because I guess
I know, that's why I had to bring out all the extra.
they have all these ideas and they don't know what to do. Like, why don't we do that? Why don't we do that? After a while, it's like a lot of not everyone thinks space is fine. Not in this environment. This environment is how I feel. And I don't give a fuck about it.
This is
On this slide.
I did my
No, that's easy to remember. Like, you'd be very serious about it, and then like,
I'd be yelling at people.
yeah, and you'd be like, hey, question, how much you guys? Yeah,
Same office.
but like, when we were at your teachers, like, you don't do academic work, so it's
I know people for years.
like,
Four of us got it.
Where else?
I know.
I chose three. I chose one. We broke out two. And the other two were fairly freshmen. They both chose three. And got three. Four, it's about 4 out of 4 for you.
That research facility.
You were at Rutgers. So you know, Sarah? It's the aviation research program. Yeah, so we're in the same, Sarah, so it's the same, like, organization, Alpha and MRDC. Just like headquarters is at different districts, the largest research under them. You family with that agency, but it's all in the same.
They have one here for the current, right?
Yeah, ISR's here. ISR's here, Sarah, Natick. It's a whole bunch of little ones in like. How long were you guys doing? I was only there for like 2 years.
Maryland. Out of DC. It's a beautiful place. It's small. 24-hour gyms.
Everything is there, but it's not a place, but like what space force so like the space force people in the Air Force, they're all three Marines, like everyone's there, super not true. Basic stuff. Like here, we're like, so it's like right outside Bethesda has rare. Which we technically own, like, considered an annex of the Have you ever seen the movie about like that's what it's on.
Or anthrax too. They say that's what like
Basically, like, that's what like all they do is like bio and stuff coming out of. I do bio work research.
local say that. They think it's for like the mRNA.
PSL 4. Yeah, like the high tech PSL. It's a high speed assault attack.
It says you can actually PSL 4.
No, it's the high those guys. Other PSL 4 lab. It's the highest one in the world. No, we weren't lab tech. We
Get hazard pay.
We were like, we weren't lab tech in like
I know people that get
no, there's like no all like
we were not.
yeah. I ran schools and like, you like as or like whatever, like we have chance like that like smallpox there's a like there's a whole like alphabet shit
Yes, you guys know the one is very long. A lot of times you see psychiatric short stuff. I'm not gonna do that. Or I'm like, aha, man,
They send a lot of techniques back in the day.
that's going to be very clear cut with how like or have a history of other stuff.
how long have you guys
Okay, so we'll go ahead and we'll get started on the psychiatric medications. So I didn't make any adjustments to this slide deck yet, just because I still think it's pretty applicable. And really what we're trying to do is we're trying to hit the wave tops of the stuff you guys have already covered. So the expectation is you guys have already gone over mechanisms of action, you know the side effects, you know the adverse responses, you know the drug categories. So a lot of that's going to be fair game. Like, but this isn't a pharmacology course. I'm not going to ask you what's the mechanism of action for an SSRI, right? I can still ask you what the side effects are because that matters. You need to appropriately counsel your patient. I may ask you what the worst outcome is when you're talking about like serotonin syndrome because again, if you're going to prescribe a med, you need to know what the bad outcomes can be. But we don't need to go through every single med in depth again. So this lecture, it's like 80 slides, but we're really focusing more on the wave tops. And these meds will stay with you throughout the entire psychiatric course, okay? So, psychiatric meds, this is what we're going to break down. So again, you guys have already had all of these, so we'll just kind of skim them again real quick. And luckily, you guys just had your last test, which is great. That means I don't have to work from a hole or anything like that. You guys are already knowledgeable, which is awesome. I have faith in you guys. You guys did well, you did bad. I have to know. That was great. It was all of you all at once. And collective grief. It's okay. Stop pulling it. You guys have not had 12 months. All right. So first one's up. We're going to talk about our antidepressants. So again, remember the main purpose behind our antidepressants is we're messing around with serotonin, norepinephrine, and a little bit with dopamine. Those are our big three that we're going to target. And we're basically playing with those, trying to increase levels in certain parts of the brain, right? All of our antidepressants are always going to have this black box warning for that increased risk of suicide, most commonly being in our teenagers, essentially, right? To about 25. That's the biggest risk, but I counsel all my patients regardless of their age, right? Next, bipolar disorder. So remember, antidepressants, they run that risk of switching somebody into a manic state. So if somebody has that strong family history, or they have a diagnosis of bipolar disorder, you need to be cautious using SSRIs. Right? This is just the areas that we're targeting. Each one of our meds, it attacks a different receptor, and we're hoping to get a response. Each time I hit one of those receptors, there's going to be repercussions downstream, right? Because I can't just target one singular receptor. If it's a TCA, I'm going to hit those alpha, those histamines, the SNRI, the SSRI, like all that stuff, right? So remember with your meds, we do our best to target, but a lot of times we're getting other effects that we don't necessarily like, and that leads to our side effects, right? Those are your big chemicals in your brain that we're talking about. Some other ones that we're going to introduce, they don't necessarily play a strong part in what we're doing. If we're talking about oxytocin, that's kind of released a lot when you're in an intense relationship, when you've just given birth, when you're lactating. That kind of helps form that human connection. That's kind of like your purpose for oxytocin. Your endorphin, this actually kind of works as like a painkiller. So if you've ever been running for like a long distance run, you have that super bad pain and then you kind of enter that runner's high state, that's your endorphins kicking in. They're blocking down that pain, right? It's a survival mechanism for your body because again, we all, if you follow that train of thought, we all developed from basically a lizard, right? And our lizard brain was all about survival. That lizard brain is still in there, and when you enter that fight or flight state, lizard brain takes over, and it's going to do everything it can to survive. So that's kind of like your rundown for endorphins, right? So first one up, we have our SSRIs, which you guys have already covered. These are your big ones. So citalopram, escitalopram, fluoxetine, not to be confused with fluvoxamine, right? paroxetine and sertraline, right? So all of these, don't mix these two together. This one, remember, it has that black box warning for the QTC prolongation, which is why we don't go above 40 milligrams, and why we don't like to use it in patients that have cardiac issues, right? Paroxetine and sertraline, so these two. Remember, these two are FDA approved for PTSD. They're our only ones that are actually have that approval, which makes them unique. Next thing, keep in mind with paroxetine. Paroxetine 1 makes you fat, and 2 makes you sleepy, right? So that's why we like to give this one at night, and we can actually use those to benefit us if we have a patient who's underweight or not eating or they're not sleeping. Sometimes we can get a 2-for-1, right? Fluvoxamine only has one singular indication, and that's going to be OCD. That's why it's kind of like the forgotten SSRI, because we really only use it for that one singular condition. It also tends to make you super drowsy. Fluoxetine, Prozac. So remember what makes that one unique is it has that super long half-life. So we're talking about like 8 days in total for the metabolite and for the med itself. So if I have a patient who's constantly forgetting medications, they're not super reliable, this can be a great option. Also kind of keep in mind that the downside effect to that is if they're having a bad reaction, it's going to take a while for that to wean out of their system. You have to deal with those bad reactions for 8 or 9 days, depending on how quickly they process those meds, right? And escitalopram, this is kind of a similar mixture to this one. Not too much unique about it. Dosing is super easy. It's literally like 10 milligrams, 20 milligrams, and that's it. But you have to still kind of be careful in patients with heart conditions just because it is a very similar mixture to citalopram, but it doesn't have that FDA black box warning, right? So that's what we're doing with these. We're kind of targeting that serotonin. Onset of action, remember, it's going to take 2 to 8 weeks to tell if this medication is going to work, which is why if they're under that 2 weeks and that med's not doing anything, we want them to continue on and keep taking it. In reality, when I'm in practice, I don't see my psychiatric patients back until 4 to 6 weeks because I want that good trial on the med to make sure that it's working. So psych meds, they're not quick, especially your antidepressants. It takes time to tell if they're going to work, right? We use it for all of these different things, and we'll talk about all of these conditions, and you'll see how these meds can be used for those conditions. We like these because in cases of overdose, because again, we're dealing with a patient that the population that's prone to suicide, if they take all of these pills at once, it's less likely to lead to cardiac arrhythmias and death, whereas TCAs, they have that black box warning for the cardiac issues, right? Specifically that QRS white complex tachycardia, which the cue for that is sodium bicarb, right? Remember, don't mix up your treatments for the bad outcomes. All right, most common effects, so your GI symptoms, your CNS depression, your weight gain, specifically with paroxetine, and your sexual dysfunction, which is going to be pretty common for all of our SSRIs. Remember that sexual dysfunction kind of take those 3 different flavors, so it's not just ED, there's a lot of other things that can go along with that. And if sexual dysfunction is the primary concern for that patient, there's other meds we can use which aren't associated with that. They're not known to cause that. And sometimes those are a better option for those patients. Right? GI symptoms, so believe it or not, just kind of as a side note with GI stuff, so you have these serotonin receptors that are essentially throughout your body, and a lot of them tend to congregate in the GI tract, which is why when we're causing those blocks, you get a lot of the GI symptoms. But over time, those tend to go away. A lot of patients will adjust to the med and they'll be fine. So one of the tricks of the trade I've kind of developed when I'm talking with my patients and I'm talking about symptoms is I'll warn them. I'll be like, hey, I'm going to start you on your Zoloft. You're going to get some pretty bad diarrhea. You might get some abdominal pain, some bloating. You're going to have some GI issues, right? Believe it or not, that's actually a good thing. That means that the medication is working because I know for a fact I'm blocking your serotonin receptors, right? So if you warn your patient and you educate them and you can kind of play it as a good thing, a lot of times you'll save yourself a follow-up appointment where they come back and they say like, oh, I stopped taking the med because it gave me horrible diarrhea and I stopped it after a week. You're like, okay, so we didn't do a trial treatment, you didn't take your med appropriately, so we're essentially back to square one. I need you to restart your Zoloft. And we need to do it for 3 to 4 weeks. where if they can say like, oh no, doc warned me about this. He said that to expect this. This is a good thing. It means the med's working. They'll keep going with that med and they'll push through the bad effects of the medication, right? So there's a little tip if you guys want to use that, or you can forget it and move on. That's fine too. Right? Adverse effects. So your SSRIs are not really known to cause this. That's why I didn't really tell you guys that. You would have to be either be super sensitive to the med to cause this, or you have to be on high dose, like above the FDA limit, and you usually have to be on a lot of them to start to cause this, right? So realize, yes, it can happen, but your SSRIs are not the ones known to cause this. This is really your antipsychotic meds, right? Good. Abrupt discontinuation, with all of the exception being fluoxetine. Fluoxetine, you can usually have somebody self-titrate off, which they can just stop the med on their own, and they'll be fine. That's why I like that med. With your other ones, we never want our patients to necessarily stop cold turkey. We always want to take them off slowly over about a week to 2 weeks to 3 weeks. And during that entire time, I'm discontinuing the med. I'm making sure they're not having a re-flare of their symptoms. I'm making sure that suicide is not coming back and becoming more severe. So that could be a sign that, hey, I know you wanted to stop your med. Let's bump this thing back up and keep using it, okay? And there's your citalopram warning down there. All right, so that's our SSRI. Yes?
So you're gonna include brand names with the generic names for the drugs?
I technically don't have to. I can, yeah. I'll do my best to make sure I do that. But just realize, just a word of warning for that, when you guys sit for your pants and your pantry, they don't usually include generic, the trade name or brand name. They're usually only gonna have the generic that's in there. That way it's standardized across all the tests and regions for the US, right? So just realize when you guys sit for the actual test, it's usually gonna be that generic name only. But when you're talking with your patients, a lot of them, they only remember the brand name, especially because of the commercials, so a lot of times that's how you communicate with them. So it's fun, you get to learn 2 languages, it's great. All right, SNRI, so moving forward. So remember, we have duloxetine and venlafaxine. These are gonna be your primary 2. These are the ones that get the most use, that you're gonna see. Yes, we learned some of those other ones. Those tend to be less common, more specific to the psychiatric realm. If you guys remember these 2, you'll be doing pretty well when it comes to the psych questions, okay? Remember, black box warning for those. They also, duloxetine is great because it has that indication for chronic pain, fibromyalgia, post-neurologic pain. So it's a great option with that. Then the vaccine is great. We tend to use it, it actually can be used in PTSD, so it's a great option for those. When you're talking about these blood pressure, it's going to matter. So if you have somebody that's hypertensive and you put them on an SNRI because you're messing around with that norepinephrine, there's that risk you can worsen their blood pressure. So you always want to be aware of that and monitoring their blood pressure when you're starting one of these drugs. All right. Otherwise, black box warning stays the same. Venlafaxine, just kind of as a note, the dosing. I know I'm not testing you guys on dosing. The dosing for venlafaxine is a pain in the butt. It starts off at like 37.5, so it's this really weird dose, and then you can take them all the way up to like almost 425. So you have to see these patients pretty consistently. And then the vaccine, the window for it is pretty narrow. So if you have a patient who takes it every single day at the exact same time, then the vaccine can be a great option. But if they're kind of all over the place and they kind of miss it by a few hours, within the vaccine, the half-life, it can be pretty significant. So they can actually go into some of those withdrawal symptoms because they missed the window for the vaccine. So you always want to warn your patients when you're working with that one. All right, there's your mechanism of action. Remember, now we're starting to hit a little bit on those cholinergic effects. Not as much as TCAs. TCAs are definitely known for it, but you can kind of start to hit that nausea, the dry mouth, that's your choline, headaches, dizziness, somnolence. This is more kind of with the SRIs. Usually I tend to see more insomnia when I'm talking about my SNRIs because they tend to be a little bit more activating, right? Sexual dysfunction stays the same. And then down here you have your other ones, like I already talked about with blood pressure, okay? All right, moving on. TCAs. So, when you're talking about your TCAs, these are the primary ones that we tend to care about. These are the ones you're going to see a lot. I usually don't use TCAs in the psych world. Usually what you're going to see is somebody starts them on it for migraines or they get started on it by pain management. And if I see that medication already in their list, rather than adding on another med, if I'm feeling comfortable with the patient and they've tolerated the med well, a lot of times I'll just tinker with the med that's already on board, and that way I kind of get increased compliance and stuff like that. Just be aware of the risk factors when you're talking about TCAs and when you're doing that, right? So again, we're starting to block that SSRI, SNRI. Depression, we don't like to use it because of that overdose risk. We like to use SSRIs more for the safety profile, right? Anticholinergic effects makes your BPH, so benign prostatic hyperplasia, that's prostate, tends to make it worse because it dries you up. Now all of a sudden you got a guy who can't pee. Can cause some issues with that. Otherwise, I've already talked about all of this, so I don't think I need to rehash it again. Okay. Cautions and warnings, like we already talked about. This kind of stays the same throughout. Cardiovascular is always going to be a concern when you're talking about that. Life threats, again, those cardiac arrhythmias when they tend to overdose. And don't forget, your reversal agent for this one is sodium bicarb. If you're doing QTC prolongation because of your antipsychotics, then you're going to use magnesium. If you send them into a hyperthermic state, so malignant hyperthermia, then you're going to use dantrolene, right? And if you caused it by serotonin syndrome, then you're going to use cyproheptadine, right? So again, don't get those mixed up. They all have a specific indication, okay? NDRIs, so this is that other category that don't really fit neatly into one of our other ones. So, Wellbutrin, that's like our big go-to. You'll see that one a lot. It's used for multiple different things. So it has that indication for anergic depression, has an indication for smoking, can also be used for somebody who's concerned about weight loss, can also be used for sexual dysfunctions. Biggest thing with Wellbutrin is don't recommend using it in a patient who's anxious because it is activating. It tends to make that anxiety a little bit worse, right? It also can be used off-label for ADHD, and it also, believe it or not, has that, hold on, my train of thought just derailed. Moving on. That's how my brain works. Sorry about that. All right. So, off-label, so it actually has that less likelihood for those sexual dysfunctions, right? So if you have a young guy or gal who's super worried about sexual side effects, bupropion can be a great way to go with that. Sometimes we'll also use it to augment. So it's not going to give somebody an erection, right? That's not what that med does. But if you have somebody who just has no sex drive or low libido, that's where we can start to use the Wellbutrin and help with those ones. Okay, so you also have to identify what the patient's complaining of, tailor your med to that one, right? Anorexia, bulimia, and alcohol. Remember, Wellbutrin in a patient who has a seizure disorder is a bad option because it's going to drop that seizure threshold, and you don't want to deal with that risk, okay? And then wise, these ones, I'll be honest with you, we don't really use these in psychiatry. They're very much like a very niche drug. You have to be kind of specialized to use them. They tend to get used more when you're talking about Parkinson's disease, so neurology tends to use these a little bit more than us. But they still exist. You still see them. You'll still get tested on them. They're usually focusing more on like the side effect profile, the hypertensive crisis. Don't eat crazy foods or dietary restrictions, right? This one, it causes that irreversible block, which is why it's bad, because you need that enzyme to recreate itself, and that takes time, and it hits throughout the body. So if you have other foods that are releasing tyramine, it can enter that hypertensive state because there's no enzyme to deal with it in the body, right? That tends to be used for treatment-resistant depression. I'll be honest with y'all, I would rather go over to ECT before I would even jump into my TCAs, right? Adverse effects, like we've already talked about, right? So again, they're fair game. They're on the slide deck. Right? So serotonin modulators, I know I'm going pretty quick because again, you guys have already had these lectures multiple times. Any questions so far? This also allows me to grab a sip of coffee. All right, cool. Moving on. All right, so serotonin modulators, this is kind of like that other category again. So trazodone, mirtazapine, this one's been discontinued on the market. You don't really see this used anymore because of that risk for hepatic failure. So it's something to be aware of. You might still see it sometimes, but we don't really use it. It's more just be aware it causes that black box warning. Trazodone is great. It's not used as an antidepressant. We use it more for that sleep onset insomnia, is where it tends to get a lot of its use from. Just as a side note, again, kind of for clinical knowledge, just for y'all's education. So trazodone, it can be used as an antidepressant, but only at doses above 200 milligrams. That's a crap ton of trazodone to be taking. And if I'm dosing it that way, a lot of times what I'll do is I'll give them a huge dose at night, because it tends to help them sleep. And then during the day, I'll divide their dose up, and they'll take like 25 milligrams when they first wake up, and 25 milligrams at lunchtime, right? And now all of a sudden I have a dose constantly circulating throughout their body, and it tends to help more with anxiety and stuff like that. So if that's the only med you have available to you, you can still use it. You just have to be a little bit more creative with the dosing. But in general, for kind of like testing purposes, you're tending to see more use for sleep, dosed at night specifically, okay? Mirtazapine is a great drug because it also tends to hit on that dopamine receptor at super high doses. It also, at low doses, makes people super tired and sleepy, so we give it at night. It also is most likely to cause weight gain, so you always have to be careful in a patient who's already overweight and obese when using this medication. But if you have somebody who can't sleep and they're super underweight, mirtazapine can be a great adjunctive medication to use. Just realize if you're going to use it that way, you have to go with a low dose, because the higher you go in dose, the more activating it gets, and now you start to reach that threshold where you're starting to use it more for like an antipsychotic realm, okay? Considerations. So again, believe it or not, there is a strong genetic component when you're talking about meds, and we can actually do pharmacogenetic testing. The utility of that is not super high, because basically it's me saying, hey, you're a cytochrome P450 inducer, these meds are going to work best for you, and you're still going to take your best guess, right? And also, pharmacogenetic testing is super expensive right now. You're talking about $1,000 to $2,000 to order at the lab. So we don't do it a whole lot. But you can actually order it, even as primary care, you can order it and kind of use that to inform your decision. I tend to use that more in patients who are treatment resistant, so they're having a hard time. I've burned through multiple meds. Sometimes going that route can be helpful. The easy way to do genetic testing is straight up ask the patient, like, hey, has your mom or dad ever had a mental health condition? They have. What meds did they try? Did that med work well for you? Because again, you're sharing genes with your family, so there's a higher likelihood Prozac worked for mom, Prozac will work for your patient, right? Cheap way to do genetic testing. Goal, response and remission. Again, we generally want to see a 50% reduction in those target symptoms. We use that. We're using the PHQ-9, the GAD-7, your screener forms. That's what they can be great for, because it gives you a number to tie to their symptoms, and you can actually watch it decrease over time. So that's where it can be useful. It also is just the symptoms the person's reporting. And the big thing I'll say with this is just because, hold on. Just because somebody's having a reduction doesn't mean you stop the med, right? So once I have somebody in complete remission, I want to continue treatment usually for 6 to 12 months. I tend to err on the side of 12 months just because so many things can change in somebody's life. I don't want them to have a hard time and then jump right back into their major depressive disorder. So once they've hit remission, we continue that treatment on for about 12 months, okay? Good. So your psychiatric meds, this is your quick rundown of everything that we've already talked about in a nice chart form. It's pretty decent. Good. There's your other ones where you're talking about the side effects and what the meds can cause. All right, so adjusting therapy. So again, we usually like to wait about 4 to 6 weeks before we tell if the meds are going to be working or not. That's where we're getting that from. Remission, so 4 to 9 months. If you add the 6 weeks to the 9 months, that's how you start to get to that 12-month category. Just realize we don't just stop these meds once somebody goes into remission, okay? And I have many patients that stay on their Zoloft or Prozac throughout the entire their life, right? It works for them. There's no reason to take them off because they go right back into their depressive state when you take them off, right? Good. When you have to discontinue or when you have to switch meds, you always want to have a washout period and you always taper them over time. Don't just let them stop cold turkey, with the exception being your Prozac or your fluoxetine, okay? Good. Here, this is your augmenting agents. You guys have already seen this slide a couple times. I don't think it's legitimately changed. So these are all options that you guys can use. The one addition that you guys are probably seeing is ECT, so elective convulsive therapy. ECT is great. ECT is highly effective. It works really, really well, but we don't ever use it first line. You have to be treatment resistant before I would send you for ECT. And the reason for that is, one, society, thanks to the media, has a very negative view of ECT. Because if I look at you and I say, hey, I'm going to shock your brain and then you're going to be feeling better, right? Us as people are like, oh, electricity is bad. I don't like that. So that's why there's kind of a negative connotation to ECT. And also, the one notable side effect to ECT is it actually causes retrograde amnesia. So essentially, once you've had the treatment done, you forget about the preceding 24 to 48 hours for just a blink. They won't remember that at all, and that can be pretty disconcerting to the patient. But otherwise, your risk factors for ECT, they're not any higher than any other surgery where you have to undergo anesthesia, right? So there's not a higher likelihood of death. It's not going to shock your brain and then you have lockjaw or anything like that. But because of media and that risk amnesia is why we kind of reserve it last line. But for some patients, they just come in every 6 months for their ECT. It works wonders for them. Right? Serotonin syndrome, like we've already talked about, they get super hot, they get super confused, and then they have a huge increase in their meds, usually because we add multiple SSRIs all at once. And then we want to know our reversal agent, so stop the medication, supportive therapy, worst case scenario, criproheptadine for serotonin syndrome. You've seen this slide before, so I don't need to belabor that. Okay. Serotonin syndrome from Up to Date. Everybody loves a good algorithm. I kind of never understood it because I had a hard time following arrows. But if you like algorithms, like arrows, there's a good option for you, right? Good. That's from current. When you're talking about treatment and stuff like that. Again, biggest thing is know what the offending agent is. Target your treatment to the offending agent. That's where you need to have a good med rec, know what they're on, or ask the patient what they're on if they're still with it, or ask a family member, okay? Again, this is from Up to Date. This is kind of like a quick note. I'm not going to test you guys on this slide in specific just because it's from Up to Date. I want to try and use your guys' textbook or the other slides. So this one, it's just kind of for knowledge that you know, but really we're looking at these other slides for testing material. Cool. All right, use in pregnancy. You guys need to be comfortable doing family planning with your patients, especially in our population, because they tend to be young, starting their families. You got to be comfortable talking to people about the meds and what they're going to cause during pregnancy. And that's where I bring up that inter-risk assessment. I will legitimately bring that up, and we'll go through it together in clinic, right, when I'm talking with them. SSRIs, generally safe with the exception of Paxil, because it's going to cause that heart defect in 1 in 20 or 25 births. So I usually will take them off of Paxil. Med choice is always going to be Zoloft in pregnancy. I'll always try and switch them to that unless they're already stable on their med. I was taking care of a patient about a month or so ago. She'd been stable on her Zoloft, stable on her fluoxetine and stable on her hydroxyzine for like a good year, and she recently found out she was pregnant. So I sat down and I told her, I was like, hey, listen, Zoloft is the med of choice, but these are the risks. We're going to have to titrate you off of one drug, start the other one, and I don't know how you're going to respond to the Zoloft, right? Whereas with fluoxetine, it's not the preferred agent. They're relatively safe. You're going to be at that increased risk for missed abortions, early birth, serotonin syndrome, all that other stuff. But you've had a really good response to the Prozac. You're doing really well on it. We don't necessarily need to change it. Choice is up to you. So you always want to counsel your patient, offer them a choice, and clearly explain the risks and benefits, right? And she actually decided to continue on with her Prozac. She's doing well. St. John's wort, we didn't really talk about this. This kind of gets into the off-label, over-the-counter FDA stuff. Just realize your patients are on TikTok, they're on the internet, they're talking with family members. They're getting all sorts of stuff. And when you're talking about herbal supplements, it's an unregulated market, it's uncontrolled, and they take it all sorts of weird routes. I had patients who were smoking valerian root and like ashwagandha. And I'm like, dude, you shouldn't be smoking herbs. It's probably a bad thing. And I have no idea what's in that. So if you pop positive, you're on your own. Like, there's no way I can justify and defend you for that. So I highly recommend that you stop doing that. Okay. treatment, antidepressants. Now we're going back to the original. Ugh. So, antidepressants, yada, yada, yada. Cool. I don't think there's anything I need to belabor too much on this slide. I think we've already hit it multiple times. All right, jumping into our antipsychotics. So these are all your reasons that you're going to use your antipsychotic, which we've already kind of talked about. In general, we're really focusing on schizophrenia, bipolar disorder, and psychotic. We don't use it as much in these other conditions. They tend to be used more in like that second, third line effect. So you guys as primary care, if you're starting to reach into that second or third line, I would just refer up to psychiatry. You guys should definitely know your first and second line treatments. Really third, fourth, even second somewhat. Okay? Elderly patients are always going to have that black box warning. We don't like to use antipsychotics in old people because they're more likely to have cognitive decline, slip and fall, and bad outcome over time. It's on that Pierce criteria. Right? So remember, we have our typicals and we have our atypicals, which are also our first generation and our second generation. Those words can be used interchangeably depending on the textbook you're using and where that person was taught at. We're using it kind of to divide what they target. So your typicals are predominantly dopamine, your D2. Your atypicals, less so on the dopamine, more so on the 5-HT inhibition, depending on the region of the brain, okay? Boom. So we always like to start with a second generation antipsychotic if we can, because it's less likely to cause EPS symptoms, which are those movement disorders, akathisia, tardive dyskinesia, torticollis, things like that. But our second generations are more likely to cause weight gain, metabolic syndrome, sexual dysfunction. This is where you're kind of talking with your patient. Some patients are willing to put up with a little bit of a tinker or a twist if it means that they're not getting fat and obese, right? So always have that conversation with your patients. This down here, just realize, like, once you go on an antipsychotic, if you are diagnosed with, like, schizophrenia or one of those psychotic disorders, a lot of times you're doing lifelong. If it's bipolar disorder, if it's, like, psychotic disorder linked to depression, those treatments tend to be a lot less and they can come off of it. But if you're getting one of those other significant ones, you're going to be on it for life. And you're just kind of doing your best to deal with it with all the nasty side effects that go along with that. Okay? So those are your side effects, so EPS symptoms, like we've already talked about. This one, remember, if you're sending out a patient and you document in your note that they appear restless and they're antipsychotic, that's akathisia. That increases their risk for suicide long term. That's a bad outcome. You always need to be aware of this one, okay? Tardive, remember, it's always late to the party. So this one can show up years to months after they've been on their antipsychotic. We make a change, they get sick, a new med gets added. Now all of a sudden that one shows up. Your dystonia, that's a really severe, painful muscle contraction. And then we want to treat that and get that under control. That one tends to show up relatively quickly. Good. So your low potencies, these are your two. Remember this one, we don't really use it, but it has that black box warning. Promazine, that was your initial one. That's your go-to when you're talking about first lines. We like to use that one. And then haloperidol, that's like your other go-to because Haldol comes in many different variations as far as routes. I can give it IV, IM, IO, PO. Like I can give Haldol every which way, which makes it a great drug. Just realize again, when you go on IV, it tends to increase your risk for UTC prolongation, makes it more severe, right? Torsades, so remember that's your cardiac arrhythmia that tends to show up, right? Second generation, like we've already talked about, less risk for that, more likely to cause weight gain, sexual dysfunction, metabolic syndrome, over and over again, right? So there's all of your atypicals that are listed on there, right? You have to keep those in mind. Good. This is that same pregnancy side that you guys have already seen. There's really not much variation with that. If somebody is pregnant and they have schizophrenia, we definitely want to keep them on their antipsychotics. If somebody is bipolar, we definitely want to continue them on their mood stabilizers. If they have a psychotic break, yes, they're pregnant, but we need to get that situation under control. So we will use antipsychotics and things like that in pregnancy. We just need to warn them about risk to baby. Always educate your patient, right? Good. So benzodiazepines. You guys are probably taught that you can use benzos for a lot of different things. And the truth of the matter is you can, but we don't like to use them long term, and we really kind of are sketchy about using them short term because of that risk for abuse is very high when you're talking about benzos. I really like to use them situationally. So if I have a patient who needs to get an MRI and they're super claustrophobic, heck yeah, 5 milligrams of diazepam will calm them down when they're anxious. I can get that MRI study done, 1 or 2 tabs. I have no issue doing that, right? That's great. It's when somebody has anxiety and another provider started them on their Xanax and now they want to keep using their Xanax, that's where it becomes a problem, right? Generally speaking, we're talking about benzos, the shorter the half-life, the higher the abuse potential. The longer the half-life, the lower the abuse potential, in general. Good. So that's all of your benzodiazepines. We were talking about half-life, right? We tend to use, midazolam gets used a lot in the OR setting. Xanax, aprazolam tends to get used a lot in the outpatient setting. And then diazepam tends to be our go-to when we're talking about all long-acting drugs. It's a pretty good one to use as well. In my practice, those are like my 3 that I use. But there's a lot of them that are out there. It was a drug class that was developed pretty quickly just because, again, it worked, it was effective, and we didn't know until later on that it has a lot of the other side effects associated with it. Right? It causes a hangover effect because you have to remember we're acting a lot on those same receptors that alcohol acts on, which is why we can use benzos to treat alcohol withdrawal. We're hitting those exact same receptors. It's also why when you're talking, one of our future lectures where we're talking about substances of abuse, in general, there's only 3 drugs that are truly going to kill you during withdrawal, right? One of them is alcohol, the other one is benzos, the last one is your barbiturates, because they all act on the exact same receptors. If you withdraw from meth, like yeah, you're gonna be cranky, angry, but it's meth itself, the withdrawal is not going to kill you. If you withdraw from opioids, you're gonna feel like crap. It's like probably one of the worst withdrawals out there, but it's not in general going to kill you. Big asterisks everywhere, right? Other problem when you're talking about benzos, that amnesia effect that can come across with them. You have to usually be on higher doses for that to occur, but it is something that can happen. This rebound anxiety, that's a pretty serious one. That's why Xanax, it used to get used a lot, but we really don't like to use it anymore. Patients love their Xanax though. Because what happens is, you're super anxious, you have anxiety, you have like panic anxiety attacks, right? You go in, you get prescribed your Xanax, hey, the moment you start to feel your stress, your anxiety, that overwhelming sense, go ahead and take your Xanax. It works, it gets it under control, right? But because it has such a short half-life, it wears off, and now also those anxiety symptoms come roaring back, so you need another Xanax. Gets it under control, and they come roaring back. So now all of a sudden you're chasing the Xanax dose, and that's how they burn through their full supply, right? So that's why when we have to use a benzo, we want to use one of the longer acting ones. It tends to taper off a little bit easier, less potential for abuse. And we all make this mistake. When I first started practicing, I made that mistake once with a patient. She came to me in Korea, forward deployed. I had no psych resources really up with Casey Hovey. Super anxious to the point where like she couldn't present in front of the commander. She couldn't do her job. She was isolating herself in her room because the anxiety was so bad. Like, I got you. I learned about benzos in class. They work well. So I started her on Xanax. Worked great. She was under control for like 3 or 4 months. But then she started coming back for the Xanax, needing the refills a lot quicker, was burning through her supply a lot quicker. So eventually I was like, hey, like we can't do this anymore. Like I need to get you on an SSRI and another med. And she got quite angry with me and it caused some problems, right? So just be aware also that drug replaces the anxiety itself, right? The chasing it. And we all make that mistake. Okay? Like I've already talked about, a bunch of different times. Good. Pregnancy. Again, this is where you have to kind of educate that patient, let them know what your risk factors are, let them make that decision when you're using these. In general, benzos are not really known to cause like a teratogenic effect as best as we can tell, but we also don't do randomized controlled trials on pregnant women just to see what happens, right? It's kind of frowned upon. Geriatrics, again, bad because it causes that cognitive decline. Now all of a sudden you have a patient who's more likely to slip and fall, old person breaks a hip, bad outcome in the long run, right? Good. And it's a scheduled drug. Yep, got it. Good. Flumazenil is your reversal agent. However, we really don't like to give it that much because it can cause its own problems. If somebody is just having a little bit of respiratory depression, that's too easy. Just breathe for them, right? You really only want to use flumazenil when they're having a really bad response to that benzo. Otherwise, if we can breathe for them, we can offer that supportive care, we tend to go that route before we dump this on, okay? Because of that risk for seizures and things. Okay. Bipolar disorder. So again, we've talked about this as well. When they come into that manic state, we need to get the manic state under control as quickly as possible. That's where we can use our antipsychotic meds, those quick acting ones. We start that. We also start them at the exact same time on a mood stabilizer. Then as they're getting ready to leave, we kind of convert them over to just that mood stabilizer. They're always going to be on a mood stabilizer for the rest of your life. They're all bad options. You use the one that has the least side effects for that patient that's tolerable, right? If you're dealing with a female who's of childbearing age, she's not really good with her birth control, valproic acid's a bad option. I don't like to use it that much. Lithium is the tried and true. It's a great option. It's used a lot. It also has been shown to reduce suicidality. But lithium, you have to monitor it like crazy. It's a difficult drug to work with as you're getting somebody stabilized. And anything that affects that patient is going to affect the concentration in the blood, so you have to monitor it pretty regularly. Lamotrigine is associated with like the skin rash. Stevens-Johnson syndrome is like the big one that's known for that. And carbamazepine, very similar. You can have like those skin rashes and stuff like that. You can have the Stevens-Johnson syndrome, not as much. And of course, the big one being like weight gain, weight management. You have to kind of monitor that over time. All right. There's your lithium, like we've already talked about. I don't think I need to go into that too much. It's a good drug. It works well and it's cheap. You see a lot of it used in Europe. Right? That's your workup, like we've already shown. Again, I think we literally just had this test on this, so I'm not going to beat it up too much. Right? Here's some anger out there. Lithium toxicity. Again, you guys are probably going to get some lithium questions. Just accept it. Like they love to ask lithium questions. It's a drug that writes questions itself. Good. Big thing is when you first start out lithium, once they're stabilized on it, it's not uncommon to burn out the thyroid. And now they actually have a hypothyroidism with lithium, is getting it and burning it out. So you see that quite a bit. And that's usually only going to be when you first start them that, right? Cool. So again, we've already had this conversation, so I'm going to move on from there, right? So second iteration antipsychotics, those are the ones that we like to use when we're in that manic state. Good. Right? Anticonvulsants, there's your one. Again, this is kind of unique to the United States. We like to use valproic acid. It's starting to fall out of favor and for the other ones, just because of those teratogenic effects that we're starting to see. But it's still kind of used pretty well. Topiramate, you're not going to use topiramate in bipolar disorder, right? That is not what it is used for. It's used for a lot of other things, but not bipolar disorder. Good. Good. There's your benzos. A benzo, the only reason you're using that in a manic state is to get that patient under control. That's the only reason. Once they're stabilized, they're not agitated and angry anymore, that benzo is going to be stopped, okay? Antidepressants, I would leave this up to the psychiatry team. If you're dealing with a bipolar patient, I would start an antidepressant on them, but they might come to you and already be on that, and you'll have to manage it. And that's where you just need to warn that patient about that rapid switching that can occur. All right. Alcohol use treatments. Yeah, alcohol is bad. Like alcohol is a really bad drug. It can cause a lot of problems. Be aware of that. It can so when they come to see you all, they might be in withdrawal symptoms. So that's where they're having that increased anxiety, those sweats, those tremors, right? Then once that's over, they can now have substance use disorder. That's where we're switching up the meds a little bit. Or acute intoxication. You guys are going to see a lot of intoxication, especially if you're sent to like Korea, sent to Europe, and they have access to alcohol. So you get a bunch of young people who have no time and a ton of money. Like they're going to drink. You're going to see a ton of intoxication, and you guys will have to deal with it. Just be aware of that. Right. So when you're talking about with acute withdrawal, we use something that's called CWA protocol or COWS. And that's where we're actually supplementing their alcohol. You're using a benzodiazepine in place of that. Generally, it's going to be Librium or it's going to be diazepam that we use for that. You want a long-acting benzo because it's going to stay on that receptor longer. If you use a short-acting one like midazolam or you use Xanax in place, it's going to burn out too quickly. and they're gonna run that risk of going into that seizure, that DT, okay? So, this is now used in the substance use disorder. So this is not gonna be used during that initial withdrawal phase, right? That's what your benzo is for. This is now that you made that diagnosis, you're gonna add on one of these drugs, and it tends to help with the cravings. Now, Naltrexone is gonna be our first line. We like to use that. It's the exact same drugs that's used for opioids. And when we go through substance use, we'll talk a little bit more about that. Just realize for now, that's the drug we like to use. Antabuse, this kind of works on the principle of negative reinforcement. So when you take antabuse, you come into contact with alcohol, makes you super sick, makes you vomit, right? We don't really use it as much anymore because we have found it's not super effective using that negative reinforcement. Also, patients can outdrink their antabuse, and it can actually cause some life-threatening conditions because now they have way too much ethanol in the system because of the drug. It's causing a lot of other problems. Acamprosate is a great option. I also like to use it in patients who have hepatic injury or hepatic failure. This is the one that we go to. The downside to acamprosate is the dosing. You have to take it 3 times a day. There's no other way around it. It's 666 milligrams 3 times a day for a year, right? So patients have a hard time with the dosing schedule with the acamprosate, which is why it's not used as much. SSRIs are not used in this system. If you're adding on an SSRI, it's because you're targeting what is the cause of their alcoholism. So a lot of times patients have severe depression, severe anxiety, personality disorder, and they're treating it with alcohol. So now you're just supplementing the alcohol with the drug to treat their anxiety, and in theory, you're getting control of their alcohol symptoms. Right? Metronidazole, I think you guys have actually had this question like a couple times now, right? Metronidazole for hemorrhage reaction. If somebody's on metronidazole and you're giving them alcohol, you're going to cause a pretty severe reaction. Right? ADHD treatments, so these are your stimulants. We always want to use a stimulant first. It's the most effective drug that we have. If there's potential for abuse, then we go to our non-stimulant meds. In reality, we want to use, there's really not much of a difference between like our mixed combo, so our amphetamine salts and our non-amphetamine salts. So methylphenidate versus Adderall, there's really no difference between the two. Like you use one or the other, whatever you're most comfortable with. Some of the studies are saying that Adderall tends to be more effective because it's those combos versus just methylphenidate, right? Sorry, I'm drawing a blank on that word. You're good, right? Atomoxetine is a good one. This is actually an antidepressant that they found did nothing for depression, but it actually helped with ADHD. That being said, you're really only getting about a 40% response with Strattera, right? So it either works or it doesn't. If your patients are super concerned about an abuse potential, that's the one I go to. We also like to use it in kids if we're worried about that abuse potential. But just realize, like, you're talking about only a 40 to 50% response with that med. Wellbutrin can be used off-label. Just be careful. It can be that drug of abuse. I've legitimately had a patient who was crushing up their Wellbutrin and sorting it to get around that first pass, and he was abusing that. And it was prescribed for his ADHD. So just be aware it's an off-label. Clonidine and glofazine, these are good ones, believe it or not, for ADHD. We tend to use them more in kids. They're not really used in adults. You just have to be careful because you can cause that hypertension because they are like blood pressure meds essentially, right? And TCAs, not really indicated for use. They're not really used much anymore for when you're talking about ADHD treatments, right? There it is, nothing there. So again, we use the combo, tends to be a little bit better, but you can use either of these, whatever you're comfortable with. With Vyvanse, so Vyvanse is actually still pretty much brand name. You have to go through a whole like prior authorization to prescribe it. And you have to fail kind of multiple drugs before you go into using that one. It's starting to become more common in the market, but not used as much just because of the pricing, right? Good. Adverse reactions. You guys have already had this. Again, biggest thing is you want to monitor anytime you're dealing with the kids. You monitor height, weight, just to make sure that they're still meeting their growth like they're supposed to. If it's an adult, you tend to worry more about blood pressure. If somebody has pretty severe anxiety, you want to be careful using these meds because it can make their anxiety worse if you are increasing that heart rate. Good. So your non-stimulants, any patient who has a potential for abuse, you want to use your non-stimulants first. And then you can go and use stimulants if all else has failed. Just because you're trying to worry about them, those pill seekers and stuff like that, it's a real thing. ADHD is It's the most overdiagnosed and underdiagnosed disorder at the exact same time. Just because of how like many commercials are out there now, where you can just do a telehealth, get diagnosed with ADHD, and then get your med. There's a lot of problems with the ADHD diagnosis and stimulants. Good. Good. We already talked about that. Again, be careful because again, this is technically an antidepressant, so it does carry that black box warning, just like all the other ones do as well. Wellbutrin, we've already talked about this multiple times. Good. Clonidine, this is your catapress. Again, if you worry about that hypotension and sedation when you're prescribing this med for patients. A lot of times I'll use it at night is when I'll start my dosing when I'm working with this one, just to try to avoid those side effects, right? So ronfazine, same concept. Good. All right. I don't think I necessarily. This kind of matters when you're talking more about kids, because kids sometimes have a hard time swallowing pills. Adderall, there's like oral formulations. There's so many different formulations for our stimulant medications. If you're working with the pediatric population, you definitely have your options. They even come in flavors now. There's like banana flavor, strawberry flavor. So you can actually tell bubblegum, I think, is a pretty popular when you're working with the kids. They like that one. They tend to hate the banana one. I don't know why. Good. All right, we're almost there. General considerations. Again, we want to use that long-acting. So long-acting has less potential for abuse. So usually you're using your Adderall XR, your Wellbutrin XR. You want to cover them for that entire day. And if you need to add something extra at the end, that's where you hit them with a lower dose one of like 5 milligrams, 2 milligrams, treating it at night when you get home, right? Adderall dosing for ADHD is definitely an art form. You have to get comfortable with your stimulants, and never patients present exactly the same. That's why there's so much variation in the dosing schedule when you're talking about ADHD. All right, so that was the quick buzz down for all the meds. I made it in 50 minutes. Whew, any questions? And don't worry, this slide deck, what my recommendation is keep this saved, and anytime we're talking about like a certain condition, like we're talking about depression, just bring it up and have it ready to go in the background, because what I'll end up doing, I'll say, okay, we're talking about SSRIs, the approved drug for this category, right? It's on you guys to know what SSRIs fall under that category, what the side effects are, and things like that. So always going to have it going in the background if you need that quick reference back. But otherwise, this will be the one and only time we go super in-depth, like long-term, or over an hour with the meds. Otherwise, we kind of touch bases on the big ones and some of the dosing strategies, and that's it. So any questions for the medications? Going once? Yes.
Real quick, sir. So this class, I think, is the first one where we're really going to be having to choose medications, not a pharmacology class. So how much of the test, if you're willing to share, is those types of questions where you're really choosing that first line pharmacologic treatment?
I don't have the breakdown right now. So what I'll tell you, just because I haven't created the test yet, I'll probably end up doing that later this week. My expectation is you guys have already had a pharmacology class, so it's not going to be the preponderance of the questions, right? A lot of what I'm going to focus on is making sure you know the diagnosis, making sure you know what criteria are, making sure the long-term effects of their diagnoses, and treatment's going to matter, so it's going to come into play, but it's not going to be like 20 questions on SSRIs all over again, right? It's going to be like, hey, you have a person who's depressed, you want to start an SSRI, these are their side effects, this is their social life, what med do you want to use, right? Do you want to use Prozac, do you want to use Zoloft, do you want to use Paxil, whatever it happens to be. You have to make sure to pick the right med, essentially, right? Does that make sense? Cool. Anything else? Going once, twice, 3 times. All right, that's all I have for you guys. But I think we'll meet tomorrow again. Tomorrow I'm only going to do an hour with y'all, just because I have to